Please welcome the Chief Executive Officer for ASCP, Dr. Blair Holliday.
Good morning, and welcome to the general session for day 2 of ASCP 2020 virtual. The title of this general session is Clinical Lab 2.0. Why the lab? Why now? And what it really means is, where do we take the laboratory in the next iteration within our country? We've known for years that changes, technology, those in innovation, reimbursement, education, even the workforce shortage is playing into the issue as it relates to the evolution of our laboratory. But now that we're facing COVID-19, we've gone from an evolution to what's needed is a revolution. So let's talk a little bit about today. We're going to be focusing on why, when we're moving towards a volume-based healthcare system to a value-based healthcare system, that our field, laboratory medicine and pathology, has got to migrate rapidly. And the question for you is, are you ready for it? So joining us today are renowned experts and have anticipated these changes and looked into their crystal ball. And the one thing you do need to know is they're proactive. And proactive players mean that you have to be at the table. They are. And today, you will be at the table. First, I'd like to introduce you to Khosrow Chaudhrbani. He's the President and Executive Director of Project Santa Fe Foundation and Laboratory 2.0 movement.
Good morning, Blair. Thank you very much for those kind words. I think you said it well. Are you ready for the future? We all know that we're in shifting lands with immense opportunities before us. So today we're about to discuss that. So let's just jump into it, and I'm excited to share our story. To begin this very important conversation, I will borrow a concept from the book by Andrew Grove, Only the Paranoid Survive, published almost 30 years ago, yet more relevant today than ever. Andy offers the concept of the strategic inflection point. It's a point in a time in the life of business when the fundamentals are about to change. That change can mean an opportunity to rise to new heights. But it may just as likely signal the beginning of the end. Simply put, past doesn't represent the future. Here's the question I propose to this setting. Has the current lab business model reached a strategic inflection point? In my tenure as a CEO of the Tricor, the question of a strategic inflection point drove the entire process of directional strategic plan. My old friend, Dr. Bruce Friedman from Michigan, answers the question quite well. The train is moving and so is the station. Yes, we have reached a strategic inflection point and perhaps crossed it. This means we need to pack up our tent and move, and we might need to be in the locomotive of the train if we intend to stay relevant. We all have heard healthcare is on the move. Some may argue the future is already here. The current model is not sustainable, is not affordable, and it's not efficient. We're moving from sick care to well care, from heads in bed to prevention, from volume model to value model, from sample-centric business model to patient-centric business model, and from fee-for-service to bundle payment, and then pandemic arrives. Why is the current business model no longer sustainable? And why doing nothing is not an option? The current model was established based on increase your volume, fill your excess capacity, reduce your cost per unit, and maximize your contribution margin to help offset the cost for inpatient population, at least for the inner system labs, until changes arrived. Number one, the proposed legislative cuts known as PAMA and leading to eventually the bundle payment. Number two, our commercial market is shrinking to the lowest level in history due to physician employment model. And 3, consolidations, narrowing the network, limiting our ability to expand our market share based on the current model. The notion of we'll make it up in volume no longer valid. Quite the opposite. It exacerbates the problem based on the new reimbursement cuts. Not to mention, non-traditional competition such as CVS, Walgreens of the world have entered into our market, causing leakage to our current business. That being said, volume will always matter. It represents data. The moral of the story here is that when the size of the pie shrinks, it does change the table matters. We all have heard the definition of insanity, doing the same thing over and over and expecting different results. We in medicine define it a bit differently. We automate and we expect different results. In our collective view, doing nothing and weathering the change is simply not an option. We will be irrelevant. On January 1st, 2018, we officially entered into dynamic tension of 2 different business models with somewhat opposing drivers. One being volume-driven fee-for-service, facing some significant changes and cuts, and the other focused on value-driven with risk-embedded focus on outcome. At some point soon, the 2 models will intercept or converge. Clinical labs leaders' ability to manage these transitional business models will be indicative of our ability to survive and thrive in a changing lens in the future. To survive, obviously, we must keep one foot at each camp. And then COVID arrived. The good news is that COVID-19 forced to elevate the value of the diagnostic testing globally to be the center attention of healthcare. Beginning with the value of a test, the mantra soon became test, to trace, to treat. Yet Lab 2.0 will make the case that there is a whole hidden universe of measurable value between testing and tracing that could convert a reactionary approach of the current pandemic to a proactive medicine based on simply predictive value of longitudinal lab data. The intention is not to wait for the person to get ill. I refer to this as the campaign of beating them to it. So, unlike the traditional operational belief, managing this pandemic or any other chronic illnesses, Lab 2.0 will make the case the lab's potential impact doesn't end when we release a result. Rather, that's where it begins. And the test results in accumulation is the critical raw material of the value proposition of the future lab medicine. So why clinical lab? Why pathology? And why now? What are the intellectual properties of its assets of the clinical lab that gives us the reason to be so bold? First, the matter of having a seat at the table and having jurisdiction over delivery of care. Often we have not been present. Dr. Crawford, chairman of the board of Project Santa Fe Foundation from Northwell, says it well. I'm a physician leader first and laboratory specialist second. So clinical lab, laboratory medicine, and field of pathology are all part of medicine, and lab must have an essential seat at the table to not only help design the future delivery models, but more importantly, help drive the organizational strategies. Leadership in our collective view outside of the lab becomes essential stepping into the future. It's true what they say. If we don't have a seat at the table, we will be on the menu. Second, why lab becomes with the notion that lab is the first responder. For instance, lab is the first to know if the person is a positive COVID or not, has an AKI or not, or going into a sepsis or not. As the audience know well, time to diagnosis is an essential stage of diagnostic optimization, leading to care optimization, resulting to therapeutic optimization, and ultimately advancing to clinical surveillance. We all know if we miss the first step, we will end up harming the patients. Lab 2.0 makes the case that lab is the essential first step, a catalyst to amplify managing population health proactively. To be this bold, we must bring down the barriers of the lab, tell a different story, and think above and beyond just managing the analytical performance. Third, why lab? Lab touches more lives than any other sectors of healthcare, and each touch point is a structured, actionable data. It has been said that it represents greater than 70% of clinical decisions. It can verify physicians' hypothesis, it can rule a condition in, or rule a condition out. It's important to point out that Lab 1.0, as we know it today, will remain an essential part of medicine, and it becomes a solid foundation for Lab 2.0. Fourth argument, why lab? Lab is real-time value, and this is a critical handoff stage from Lab 1.0 operation to Lab 2.0. Often we forget lab is real-time with zero latency, as opposed to claims or actuarial data with a significant latency. Real-time lab data allows us to set surveillance. Now, surveillance is nothing new for our lab community. We've been doing this for a number of years in the space of infectious disease. Lab 2.0 argues that by expanding surveillance model to chronic conditions by prevalence proactively, when utilized by patient-centric longitudinal lab data repository, we can begin to measure change in patients for early stage detection. Measuring change in a patient compared to themselves is Lab 2.0 definition of precision medicine, leading to early escalation of the conversation to help move the care intervention up the stream. Fifth argument, why lab? Based on the patient-centric longitudinal data, Lab 2.0 goes to work. Mind you, patient is not waiting in ER or in hospital bed. This is no longer about a test. Rather, it's about post-diagnostic computation, translating lab data into clinical actionable insight. The visual illustration of the Lab 2.0, for instance, managing COVID, would look like this. By utilizing longitudinal lab data, Lab 2.0 can risk stratify within the population with comorbidity and underlying conditions such as heart, lung, diabetes, past respiratory conditions, and what have you. Then we can identify existing gaps in care. We can identify high-risk patients based on existing comorbidity. And last, facilitate intervention for proactive isolation or quarantine. I refer to this stage as the Uber of the medicine, the new frontiers of the lab value proposition. Clinical lab is an essential vehicle to not only help establish the disease prevalence, but more importantly, help in patient triaging and patient guiding, especially in times of pandemic, above and beyond just releasing the result. As part of our inquiry on the role of the clinical lab in the new era of healthcare, Dr. Michael Crossi and I have questioned, given our vast touch points, given our proven ability to identify care gaps and facilitate targeted intervention, what is the role of the lab in actively closing those gaps in care as we identify? How can we serve as an active participant in population health as opposed to passing on the information and hoping someone will follow up? Opportunities are intensely huge to connect the dots and add tangible and measurable value. It is critically important to note that health systems who are outsourcing portion of their lab, such as outreach, which is part of the longitudinal data, or the entire lab, it limits their ability to transition to becoming a clinical lab 2.0 as the system transitioning to become population health. Not to mention, if data is our winnable position for the future, why on earth would we want to outsource it if it cost pennies on the dollar. And last argument, why lab? Lab is the best financial bargain for healthcare. Sometimes we have been referred to as cheap date. For every dollar we spend in healthcare, less than 2 cents of each dollar is spent on total diagnostics. In Medicare, is actually 1.6 cents of every dollar, merely a budget dust. Yet information generated from this high value asset is real-time actionable to help save lives 24 hours a day, 7 days a week, ultimately optimizing the current length of stay. Yet, most importantly, we are beginning to leverage the power of the lab data to do the following as we're transitioning from volume model to value model. We're able to drive proactive clinical strategies around intervention, prevention, leading to cost avoidance, and ultimately help reduce disease prevalence, which are the key ingredients of population health improving outcome. All of this said, lab can't do this alone. Lab data aggregated with social determinants, as Dr. Jill Warrington at Aspetti University of Vermont, a member of Project Santa Fe, demonstrates to prevent opioid overdose by this combination. What if we're able to do this with diabetes, where US spends more than $300 billion annually? In summary, in population health, intervention with sick patients and moving them to a low-risk quadrant is mission-critical step. That's job number one. Yet it doesn't address the key objectives of population health. To address that, the entire population needs to migrate the bell curve to a low-risk range. Clinical lab represents the data platform and domain knowledge of pathology and disease management to do exactly that by focusing on pre-care and pre-patient and consumer wellness. We just have to figure out how to align our incentives to get paid in the process, and obviously that will not be an easy task. In closing, I will offer disclaimer. Lab 2.0 is not about selling or sharing patient data. It's not ours to do so. Lab 2.0 is about leveraging longitudinal patient data for a proactive clinical actionable insight to improve outcome and reduce overall cost. Let's keep in mind, patient owns their data, and it's all about portability and clinical stewardship. I will close with a quote from Dr. Jim Crawford, that there has never been a better time to demonstrate the value of laboratory medicine and pathology in delivery of healthcare. But it must be quantitatively proven and attributable to lab's contribution. On my own personal note, I fundamentally believe clinical lab has the opportunity and well suited to reshape the way healthcare is delivered. The work is before us. Thank you.
Please welcome Mark Dixon, President of the Mark Dixon Group, LLC.
Well, good morning, everyone. It's terrific to be with you all today, and thank you to ASCP for allowing us an opportunity to talk about Lab 2.0. I'm a former health system CEO or COO at several different health systems, and I'm just very excited about what you're about to hear about. Cosro provided a great overview of Lab 2.0 for us to kind of kick us off today. And as we mentioned, Cosro is the founder and CEO of Lab 2.0 Strategic Services and President Executive Director of the Project Santa Fe Foundation. Also joining me on the panel today, we have a very distinguished panel of experts to talk about this, is Dr. Jim Crawford, who Cosro mentioned on a couple of his slides. He's professor and chair, Department of Pathology and Laboratory Medicine, and the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's also a senior vice president of laboratory services at Northwell Health. Also joining us is Dr. Myra Wilkerson. Myra is the chair of the Diagnostic Medicine Institute and chair of laboratory medicine at Geisinger Health. and also chair of the Department of Diagnostic Medicine at Geisinger Common Health School of Medicine. So please join me in welcoming them to the stage today. What we have for you today is a panel conversation about Lab 2.0. You've just heard a terrific overview of Lab 2.0 services from Khosrow. And maybe we'll turn it to kick things off today for our panel to Jim and Myra. Jim, what first got you energized and excited about Lab 2.0?
Thank you, Mark. This has been a journey. From 1999 to 2008, I was chair of the academic department of pathology at University of Florida. And in 2006, the first of two enormously influential people in my professional life approached me, Dr. Phil Chen, who at the time ran a diagnostic laboratory in Orlando. He wanted to collaborate with the Florida Healthcare Coalition to improve the health of individuals with diabetes and prediabetes at one of the major entertainment employers in Orlando. Long story short, we were able to demonstrate that a laboratory-led program improved the quality of life for these employees and kept them out of the hospital over a one-year program. So I went looking for how to make this a more sustainable model. I found the patient-centered medical home in 2008. I went to their national meetings, and as the only pathologist there, the uniform response was, "Lab, what are you doing here?" And that was a real wake-up call. Something was missing. Here we are with this incredible value, and we were not recognized for it. The value-based era officially started with the Affordable Care Act in 2010. And so this has been the subsequent decade. The second most influential person in my career was meeting Khosrow. And in April of 2015, we were walking across a parking lot at a national meeting saying, we've got to do something. And I said, Khosrow, let's organize a meeting. Let's do something. The credit goes to Khosrow. He pulled together a group of people. We met March of 2016 in Santa Fe, New Mexico, and thus was born Project Santa Fe. I've been wanting to do this for a long time.
Started in Orlando, and here we are. Myra, how about you? You obviously are on board and energized about it. What got you energized and excited about Lab 2.0?
So Jim and Khosrow were both at a Compass Group meeting in Washington, D.C., and I was there as well as Dick Zarbo from Henry Ford, and the four of us sat down together to talk about their parking lot conversation. And when they started sort of rolling out the idea of Clinical Lab 2.0, I don't even know that it was called that at that point in time. That evolved. But the conversation was really exciting. It's like, wow, what can I do to help shape the future of laboratory medicine? What helps shape our practice? We're all struggling with this concept of what it means to go from fee-for-service to value-based payments. What does value-based medicine mean for laboratories and for pathology groups? How are we going to think about that? How do we handle it? How do we respond to the people who make the policies that will govern this? And the idea was, when I was talking to them, it's like, wow, we can form a think tank. We can be the voice of laboratory collectively, because individually it's very hard to have that sort of influence. But if we can do something collectively to demonstrate the value of laboratory medicine, this is what we need to be doing for the next generation for the next generation laboratory. What does it need to evolve to serve our patients?
Very good. There's a common thread through both of your answers there, and that is collaborating outside of your own four walls to see what others are doing. In Khosrow's opening presentation, and maybe you want to talk about this a little bit in a second here, Khosrow, you talked about coming off one curve of doing business of volume and moving to the second curve of value. What does that strategic inflection point look like? When does it really start making a difference in the laboratory's prospects for success? How do you know, and is it for everyone? Khosrow?
Mark, you said it well. Inflection point has the negative side, but equally quite the positive side. And I've always believed that if we're going to dream, we need to dream big. Otherwise, why bother, right? But we have to take small steps. to make that happen into reality. So if I'm looking at the positive inflection point of Clinical Lab 2.0, given that we are moving from volume to value when we're right in the middle of the pandemic, I could ultimately visualize Lab 2.0 resulting into our ability to reduce disease prevalence. Take COVID itself and watch the positive domino impact evolve. I can visualize how we can improve the lives of the people that we're actually responsible for. And then not just that alone, and ultimately how lab can help for health system to be more productive, especially right now where health systems are going to require to resuscitate their balance sheet. Lab is going to be a critical piece to make them productive, and ultimately leading to how do we reduce the overall cost for care and cost for population. So the last piece, how I would visualize Lab 2.0, how do we take the concept of the triple aim or quadruple aim and help it really go to the next generation, maybe even migrate, moving from patient experience to consumer as it relates to well care and how they are in charge of their own health management.
Very good.
I would say that this is for the ones that protect and preserve their clinical practice of lab medicine, and they have access to their longitudinal data. For the ones that don't, obviously it limits their ability to do this.
Excellent. Thank you, Khosrow. Jim, do you have some thoughts or comments around strategic inflection points and how do you start making that difference?
Well, Khosrow says there are negatives and positives. How about jolts? The current job I hold, I started in January of 2009. I signed my contract for this job on September 27th, 2008. And I knew at the time that Northwell Health had an offer on the table to monetize the laboratory and divest. So 5 days later, October 3rd, 2008, I had flown up, and I and the Vice President for Lab Services, Bob Stallone, met with a subcommittee of the Board of Trustees of Northwell Health to fortunately successfully convince them not to divest the lab. But what that means is before I arrived, I knew that lab had to prove its value every day. And it's something that I do not take for granted. It's our stakeholders. Yes, there's the corporate leadership, there's our board of trustees, but I think our most fundamental stakeholders are our patients. Are we the lab that should be providing their care? And the medical providers, and it's a whole spectrum, it's physicians and nurses and all the way through the healthcare ecosystem, are we their lab? And so how do we prove our value? I've been told along the way that I can't claim cost savings. Someone else has already claimed those dollars. What is the quantitative evidence that we are the laboratory of choice? And so you win this battle in detail. I think the respect of your peers is a good starting point. The fact that your patients have, as I say it, quantitatively measurable outcomes, which are very hard to demonstrate, lab's impact, to me is very motivating, and we cannot take this for granted. The inflection points are all around us.
You know, there's a theme in what I heard you talking about, and that's of leadership. And how do we lead differently in Lab 2.0 versus Lab 1.0? What's that look like for pathology? What's that look like for lab leadership? Myra, I suspect you've changed your leadership style and thought differently about leadership as you've gone through this. Could you talk about that for a second, about leadership in the lab through Lab 2.0?
So the basic idea of a leader needing to set vision, to have vision and to help set or guide strategy doesn't change. It's what the strategic direction is that needs to change. And for me personally, it's about asking really tough questions about value as we try to move into this next phase of how healthcare is practiced in this country. And so it's, what are the value of all the services that we offer in the laboratory? How do we prove that value? Where's the evidence to prove it to people outside of the laboratory, whether it's patient in particular, but also payers, our healthcare executives, practice managers, vendors, other people in other parts of healthcare like pharmacy, et cetera? How do we prove the value of laboratory services to all of them, but especially to the patient? So it's asking tough questions. So what is the value of a single test? What's the value of a battery of tests? What's the value of an algorithm of testing that you've put together? What's the value of an instrument? What's the value of one instrument versus another when they're measuring the exact same thing using the exact same methodology? Just as importantly, when is it more valuable not to do testing? We have to prove that to people, and we have to be willing to give up some of that control and say, no, we don't always need this test. This is in the best interest of the patient, not to confuse the picture. There is value in that as well. And ultimately, it's what are our services doing to help that patient, to provide value to them over the course of an entire condition or a disease? And it could be something short-lived, like a strep infection, simple strep throat, or it could be something that lasts over a lifetime. How have we decreased their observed to expected mortality? How have we decreased comorbid conditions? How have we helped manage their care better? That they can say, yes, it was valuable to use this laboratory, use this provider to help take care of me and help me make better decisions and choices.
Wow, what an answer. Just listening to the context of your answer, and your answer had actually more questions than answers in it. And it tells me that you've changed. You're asking a lot of questions that maybe aren't typically asked inside of a usual lab leadership suite. So that's fantastic. It's aligning with the strategy of your health system in a major way. Jim, what are your comments and thoughts on leadership? How have you had to change how you lead and what you lead inside of Northwell? It sounds like you had a tall order from day one.
And it's very motivating. Well, I'll first start by making sure that we observe and acknowledge the title that Dr. Wilkerson has. She's chair of the Diagnostic Medicine Institute at Geisinger and chair of diagnostic medicine for the Commonwealth School of Medicine. This is much bigger than turning out analyte results, either in the clinical laboratory or in pathology. It is leadership of medicine in a much broader scope. And so the concept of leadership includes the fact that you are taking on responsibility. This is not just saying I want more access to the candy store and I want more resources thrown in lab's direction. To have strategic ideas, to say this is what we need to do on behalf of the populations we serve, and to not just sit at the table, but to convene the table with humility. This is not about arrogance, saying there's a job to get done. Let's get the right people involved. Let's move forward. That also requires discipline, because we then become responsible for the consumption of healthcare resources. We become responsible for the costs of healthcare that are passed along to consumers in the form of their premium payments and their copays. And so the stakeholders are not just the medical providers, but you also need to include payers and the administrative side of medicine. That's an awesome responsibility. It's also an awesome opportunity. It's a totally different way of thinking about how laboratories should be driving better healthcare and trying to improve the human condition.
Very good. Thank you. Yeah, it's a much broader viewpoint for sure. Khosrow, as you provided the opening piece for today's session, you talked about new business models that are created to really support Clinical Lab 2.0. Can you give some examples of some business models that you've been involved with or that you're aware of out in the market, and how maybe they help to enhance your stature with some of the stakeholders that you're engaged with?
I'd be happy to. One point that I would love to go back to a previous question, and given the audience, I think it needs to be highlighted. Jim and Maya talked about managing the leadership, but revolution can't happen without cultural transformation. We're asking our staff to do more, especially phlebotomists, the courier, the medical technologists, and what have you, and we're trying to put them on top of their game. In my opinion, culture transformation requires a significant employee engagement. I can't imagine us transitioning Lab 2.0 without engaging. In reality. And I just want to make sure that the credit goes to where it's due. This is where, in respect to your question, when I hear the value add, and Lab 2.0 cannot be a value add. It has a really an independent economic value that is aligned with the organizational drivers and healthcare trends. And to give this away as a sort of a value add in exchange for a volume that is facing significant cut is a good way to ask for cannibalization day one. So I feel strongly that this can be retrofitted in the ways we've done business in the space of CPT code fee for service. Minimum viable product by definition really means a customer that we understand their pain point, they have to have it, and they're willing to pay for this. Obviously, Lab 2.0 has a significant number of customers, but one particular customer is the one that actually is responsible for outcome of a population at a significant financial risk. And Clinical Lab 2.0 has opportunity to provide the services under the Lab 2.0 that really augments and mitigates the pain points that individual. That individual often is in the higher level of the organization, such as CMO of the organization, CNO of the organization, Chief Population Health Officer, and what have you. So the example that I would offer that basically touches some of these pain points is how do we and these are, by the way, collective demonstration projects of the Project Santa Fe, our ability to detect the sepsis, which is number one readmission to hospitals, our ability to help manage diabetes where they won't be admitted in the future, our ability to detect and manage the CKDs of the future, or the AKIs, and we're right in the middle of developing the COVID Lab 2.0 model, which will be the centerpiece of our October workshop. I would make the argument that this is a different division, and it might be kept separate from the traditional product management, business development, because the touch points are different and requires different skill set to manage the model.
Very good. Thank you, Khosrow. Myra, you've probably had some similar learnings around business model transformation and such. What would you have to add to that?
So we have several demonstration projects going on that we work on together collectively, although not all of us work on all of them at the same time. That would be an amount of data that we just couldn't handle. But we are working on sepsis, diabetes care, early pregnancy detection, and enrollment in prenatal care, laboratory formulary, opiate testing, acute kidney injury, and then also anemia. So, what we're trying to do is figure out how to use the data, how to improve the patient care. And so I'll use sepsis as kind of an example to segue into another project that we're working on at Geisinger. That's the Geisinger at Home project. So in Lab 1.0, we say, okay, we've got a cohort of patients. They're Medicare Advantage patients and fee-for-service patients. So that would be about 8 to 10% of our population that we take care of. 55, but they account for 55% of the cost in that in our population. So how do we create value for them? How do we help them manage their disease better? What role can lab play in that? How do we keep them safer? How do we, for instance, during a time of COVID, we don't want them in our clinics. We don't want them to be admitted to the hospital because they have a lot of chronic diseases like congestive heart failure, COPD, chronic kidney disease, diabetes. They're at very high risk of getting infection and then having a severe form of that infection and possibly dying. So let's keep them home where they're safe. So Lab 1.0, we would say, okay, let's have mobile phlebotomy. Let's have home draws. Let's send a phlebotomist there. They'll They'll go draw the blood. They'll drop it off at one of our courier pickup locations. We'll run it in the lab. If there's a critical result, then we'll call the provider. Very Lab 1.0, we all do that every day, 24/7. Lab 2.0 says, what else can that phlebotomist do while they're there that can be useful to the patient, but also maybe help lower the cost of care and avoid maybe having an RN having to make some of those visits? Could they do basic vital signs while there? Could they just ask them simple questions? Do you have enough food? Do you have the supplies that you need to help manage whatever? During COVID, for instance, we've been asking them, do you have face masks and gloves so that when people do come to see you, you can protect yourselves? And we've been taking them PPE, or our phlebotomists have. But then again, so the phlebotomist does some basic tests. Maybe they were thinking about influenza season coming up, which we anticipate will be maybe worse than our usual influenza season. And we're also faced with a possible second pandemic in the form of avian flu going on at the same time as COVID. So if the phlebotomist can collect those specimens and then we take a look at it and work with nurse coordinators and our primary care doctors and other providers, PAs, nurse practitioners, and say, this isn't a critical result, but it indicates that there's a change in their disease status, and you may need to do something about that. So it's helping cover a gap in their care or a change in their condition because lab identifies it first. So for instance, going back to sepsis, if we can determine what lab or set of labs are indicating a change in your status that you're going to have to be admitted to the hospital within the next month with sepsis, and we can then notify a nurse coordinator and that person can intervene and help keep you out of the hospital, that's a huge win for that patient and a huge win for the health system overall.
Boy, this is what really excites me about Lab 2.0 as a former leader of population health at a health system. You're kind of taking some very proactive steps to get out in front of things. Mm-hmm. To do that, maybe this is a good question for both Myra and Khosrow. You have to build partnerships outside of the lab, right? You have to get engaged and visit with people, find out what their needs are outside of the lab in order to find out where we can have the biggest impact. Myra, how did you do that? Or where did you build those partnerships outside of the lab?
One of the primary partnerships, and TriCore does this very successfully as well, is we work with our own health plan, but TriCore doesn't necessarily have that luxury. They've had to identify the prominent payers in their market and build relationships with them. So it's figuring, they're really interested in anything you can do to help solve care gaps and improve coordination of care. Your chief medical officer is going to be interested in that. Anything that you can do that will show some savings or create some value, your chief financial officers and financial managers are going to be very interested in that. Pharmacy is a very critical partnership. TriCore does that very well. Northwell does that. We work with, we have an anemia management pharmacist that our blood management nurses in the lab work with very closely. Those are some of the key partnerships, but then again, who owns the data, who can help you analyze and manage large amounts of data to build the evidence that we need to prove value. Not everyone has access to that. But if you can find somebody who owns data, you may have a data analytics team if you're a larger organization. We're very fortunate to have a healthcare economist as part of our health plan. They are an incredible wealth of information in helping us figure out what constitutes value to a patient in a particular and how to model that. So those are just a few of the patients, but are few of the people to align with, but it's also primary care providers. That is absolutely critical. Yeah.
Khosrow, or anything to add to that from a partnership standpoint, or Jim, either of you?
Yeah, again, partnership to me started with my own employees. Engagement that they will be part of it, that they have your back, and because we're asking them to work harder and they had to understand the vision. Obviously, Lab 2.0 cannot happen in the four walls of the lab. It's all about partnership inside and outside. So I would identify internal partnership, meaning this is informatics game. That means partners with IT, EMR. This is a space for AI or machine learning. This is all about data, especially the holy grail of the lab medicine of future is what we call Enterprise Master Patient Index, the longitudinal data. If you don't have that, it really is going to be limited what we can do in this space. Then we go beyond the IT partnership with pharmacy. Lab is the first to basically recognize that $80,000 a month Hep C drug is working or not. What if we lock arms with pharmacy and develop products around that? And mostly population health folks and managed care office. And externally, Myra identified key individuals, but then I would go also public health within the region, HIE within the region. Those are all key stakeholders and constituents of developing Lab 2.0. And going back to what Jim initially talked about, we're a catalyst of the conversation with a very sense of humility, not that we've arrived on our high horses, but it really does happen outside, not in the four walls of the lab. So we got to go beyond our analytical boundaries.
Yeah, excellent. Thank you. Great answers from both of you on that. You know, yes, building partnerships outside the lab's critical, absolutely critical. But what about inside the lab? We probably need to do some different work around educating our teams. We need to do some different work about building it, weaving some of the Lab 2.0 activities into job assignments and job evaluations. Jim, what's your experience been inside the lab as you've kind of been on this journey now here for several years? What does that look like inside the Northwell lab?
I would start by saying it's very empowering because every laboratory professional, every member of the workforce is involved with this moonshot. The question is, are Clinical Lab 2.0 activities an essential part of your job? And I would turn that around and say each employee in a laboratory workforce, the entire laboratory workforce, has to be mindful and hopefully can contribute to the answers of the questions of how does what I'm doing improve the patient experience, improve patient outcomes, improve the provider experience? How is what I'm doing improve patient outcomes and the outcomes for the entire population? What can I do about this? And who should I be working with? That can suffuse the whole workforce. Moreover, to the extent that there is bidirectional communication amongst different levels of the workforce knows where the weak points are. They know where things are not working. And some of our major successes at Northwell have been bringing ideas from the frontline workers to improve not just the delivery of laboratory services per se, the 1.0 part, but to loft that into a 2.0 space and say, and we can do better healthcare, because the opportunities are basically at all the touch points. I would add to something that Myra said, and something I've learned from Geisinger. When you engage in Lab 2.0 activities and are pursuing quantitative evidence, you have to use the scientific method. You have to be very rigorous in how you're approaching your data. You have to shape hypotheses. You have to be honest about what works and what does not work. And you have to be transparent right from the start as to the criteria of success. It's a way of suffusing the entire way of what you're doing. As far as job evaluation and job descriptions, you know, even just taking something like patient experience, upstream defects and downstream defects are something that can be woven into the day-to-day work of people before you even begin the strategic process of how can we do things better? How can we make the human condition better?
Fantastic. Thank you. Terrific answer. Myra, what might you add to that as a leader of a major lab with literally hundreds of employees across the organization? How do you kind of work to put Lab 2.0 front and center inside the lab?
So, uh, so, uh, when we started on this, we, um, the, 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 immediately started building it into our strategic plan. We had a big strategic planning process about 3 years ago now, and it involved every level of operational and doctoral leadership within the laboratory. And so we introduced them to the concepts of Laboratory 2.0 and had a little workshop, how do you turn a simple project, an everyday thing that you do but do very well, how do you make it go from 1.0 to 2.0? And then as you're thinking up new projects, new businesses that you want to bring in, new assays, whatever, how does that align with the strategy of your laboratory or your group practice or your healthcare organization? And then you have to give them some simple tools to say, okay, if it seems like it aligns, but how does it align in terms of market differentiation and mission criticality to the organization? But then you have to weigh the trade-offs between the business value versus the complexity to implement whatever idea you're putting in place or thinking about putting in place, and do some sort of economic justification for it. So you have to have some simple, easy tools that your managers and your doctoral leaders can apply. And it's important to work those concepts into annual performance goals, for instance, maybe even into job descriptions, but certainly into your ongoing strategic planning, because strategic planning never stops. It has to be dynamic. And so it's really important to get people used to thinking 2.0 and not sticking with what we've been doing very well for the past 20, 30, 40 years.
Yeah, it sounds very comprehensive from both of you. It's not something you just spend some time in January of the year and hope it works till the end of the year. It's something that's a constant drumbeat throughout the year, I suspect, as you move it through. Well, we're running near the end of our time here today, and I want to be sure that everybody has a chance to maybe provide some final advice. So. We've got a very diverse audience with us today. I talked about that a little bit earlier. Again, pathologists, residents, leaders, many more. No doubt you've created a little excitement with all of them. You've sparked an interest in terms of what's possible and where it might go. We'll start with you, Khosrow. What final advice, what wisdom can you impart upon our audience today to help them take the next steps as they move forward after this conference?
So I think we've already shown in the analytical stage, we're almost reaching Six Sigma performance, almost perfect. But as we're moving into new era, it's just not going to be around that. So we've made the argument that lab is the first to know. We're the first responders. We've made the case that lab is the epicenter informatics, and with the domain knowledge of pathology and epidemiology. Subsequently, we're making the sort of a stake in the ground that lab, therefore, should be the command center, whether dealing with pandemic and or chronic conditions affecting population health. That means we got to expand our operation more than just order in and result out. And that really requires some rigorous strategic way of looking at the future. But start small. So the 3 steps that we did in TriCore really made it, taking the giant elephant into pieces. 1, we have to optimize the current operation that's not going to go away and eliminate waste. Number 2, we had to diversify our top line so we're not at risk of the changes coming at our way. The last piece was how do we transform our operation utilizing the predictive value of the data? And each of these sections requires sort of a peel down, how do we manage that? And highly suggest engage your entire employees of the lab all the way to your janitorial services because they're part of the strategic plan.
A lot of what I hear you say also is heavy emphasis on culture. What is the culture of your lab, and how do you begin pivoting that culture towards a different endpoint than you might have had in the past? So excellent. Myra, why don't we turn to you next and maybe ask what's your final advice? What pearls of wisdom might you impart on our audience today?
So I agree with Cosro. Start small, bite off a little bit at a time. It's an evolution. You're probably going to go from 1.0 to 1.5 to 2.0, and that's to be expected. And your entire lab can't be 2.0 all at the same time. That takes a few years to get to that point, and you're always having to reintroduce people to these concepts. But take something that you do very well and figure out how to kick it up a notch. So you might have pretty much all of us who have emergency departments, we present turnaround times on troponins. Okay, well, let's help the cardiology and emergency department staff. Let's say, okay, if we shave off 5 minutes on our troponin turnaround time, can we also present the data to show that the patient got to the cath lab faster? Let's find the data, let's build the case for them so that whenever we do even simple process improvement projects like shaving a few minutes off cardiac time, but it has a definite effect on and benefit for the patient, that's 2.0. And that's not that hard to do when you start with some simple things like that. It doesn't have to be huge amounts of data like with our sepsis project. I mean, I think they started with well over 3,000 data points. But start with something small that you already do well and build on that.
Fantastic. Start small, make a difference, keep focused on the big picture of what you're trying to improve, not just the turnaround time, for example. So that's fantastic. Jim, you're going to close us out today. You're the chair of the Project Santa Fe Foundation and a major leader in the Clinical Lab 2.0. What are your thoughts on the final advice for our audience today around getting started? How do we take the excitement that we're creating today and move it into something that they can be part of this movement?
Well, I think, thank you, Mark. Khosrow and Myra have, I think, summarized the essence. I would parse out the process, starting with educating your stakeholders and making sure that your stakeholders understand what you are setting about to do. If you are going to take action, you are working on data, and it's data that you generate. It's also data that is elsewhere in the health system. You are converting that to information from which you're getting insight, and the most important part is action. You need to be part of the action to make change. I think we would be remiss to not to shine the light for a few moments on the COVID-19 experience, which has been an extraordinary Clinical Lab 2.0 experience, because through the course of the last 6 months, we, lab, as well as the entire world community, have identified new epidemiology, new disease. We've put heroic effort into improving patient access, problem solving, educating the public, being a public face laboratory, a public face to stakeholders far and wide, being part of a regional response, and serving our communities. That's Lab 2.0. You cannot do better than that. We actually have been calling it the Lab Olympics. So what now? What can we do to basically capitalize on our visibility to serve, call them stakeholders, but every single one of these is an individual with both their lives and their responsibilities. I'd close by saying that we are having our 4th annual Clinical Lab 2.0 workshop in later October. The fee for the registration fee is waived. Can be found at cl2lab.org. This is a movement, and we invite you all to be part of it.
Well, thank you so much. That's probably a good place for us to land here. Khosrow, Jim, Myra, thank you so much for spending some time with us today. It certainly have inspired me and inspired the audience around some of the possibilities here. Thank you.
Thank you.
Good luck.
Yep.
Very much for our guests and for insightful information, and more importantly, why you and I now realize that we have got to be part of this movement. Before we adjourn the general session, just something I want to share with you, a thought in my mind as we were listening to their presentation. Remember, the laboratory's potential impact doesn't end when we release a result. That's where it begins. Have a great day.